Hi, Dr. Pelto here. I want to go over today what and when to refer to podiatry. A lot of people have questions about what they should be sending and actually when is the proper time, especially for primary care, is what they should try first. Hope you find this beneficial. I want to let you know that you can download this presentation by just clicking this QR code. I'm going to give it right now, and then I'm going to give it at the end. So if you wanted to use this, if you're a podiatrist and you want to share this with other people and do your own presentation, you can feel free. I'm going to put it at the end too. If you download it, I'm going to put some additional resources and links here for you, some educational resources too. Let's go here. What we're going to cover today is what are the most common conditions of the foot and ankle. It's not going to be comprehensive of everything because that would take forever. I'm just picking the top 10 or 15 items that are typically referred to podiatry. And then what are the initial treatments by the patient, the primary care physician, the nurse practitioner, the physician's assistant, the urgent care, prior to a specialist referral. This is going to make it a little bit easier, especially for those that are taking care of the referrals for the doctor to evaluate their notes, or also the doctors themselves to see, well, what can I try first before I send them to podiatry? We're going to look at a lot of conditions. I put a few here, but we're going to look at all of them here in alphabetical order. So let's start here with Achilles tendinitis. Achilles tendinitis is pain in the back of the Achilles region. You really need to make sure that you are not missing a Achilles tendon rupture. Once again, if you have any concerns, you should send them to the emergency room or directly to the specialist. And just for a word for those that are listening, this is not to replace treatment from your doctor or from your primary care. It's just for instructional purposes only. Achilles tendinitis is pain at the Achilles region where the Achilles either inserts into the heel or slightly above it. There's a couple of different types of Achilles tendinitis. We're not going to get into details. I'll have some details if you want at the bottom of this video about that condition. What are the treatments? Here's the checklist that I use. And what the things that you could do as a primary care or an urgent care are underlined. So you would start probably with an x-ray to see if there's any bony problem, any fracture, any things like that. Just so you know, Achilles tendinitis doesn't show up very well on x-ray. It would be better to do an ultrasound or an MRI, but you don't want to get an MRI on every Achilles tendinitis. The traditional treatments to reduce inflammation, anti-inflammatories, some type of a prednisone, icing, contrast baths. My preferred method is shockwave therapy or EPAT, reducing tightness with physical therapy, home therapy, stretching, a night splint, heel lift. That's something that you could do easily on your own along with the physical therapy. Stabilizing the foot with a custom orthotic. A walking boot goes a long way, but you need to do a high walking boot to take the pull off the Achilles. Ankle brace can sometimes help. I don't use those that much. An arch support can sometimes help. Supportive shoes can help. The ones that you could try are underlined right here. And then some of the advanced treatments, shockwave, amnio injection, if it's an area that's not at the insertion, platelet-rich plasma injection, surgery, and then maybe getting a second opinion, having someone else take a look at it. So that's Achilles tendinitis. Let's go to the next one. Bunion and a tailor's bunion. Here you can see a bunion is on the inside of the big toe and a tailor's bunion is on the outside. The treatments are very similar. Initially, you're going to get some imaging. I put ultrasound up there because if there's a bursa or inflamed sac, a lot of times I'll do a diagnostic ultrasound. Reduced inflammation, you're going to do icing and anti-inflammatories. Occasionally, I'll do a cortisone injection both into the joint or into that bursal sac on the side. Physical therapy can be helpful sometimes, but the biggest key really for a painful bunion is to reduce the irritation, and that's going to be with a wider, we call it an anatomic type of a shoe. As well, that would be a shoe that's really wide in the front. There are a couple of brands I'm going to put in the bottom of this video, such as Topo or Ultra. Also, correct toes. Those are some spacers that you can use between your toes. You could try that. A simple bunion pad. If you want to improve the joint movement, make the joint movement work better, there are some modifications you can do to a custom orthotic. And then there's some surgery. I put a few little procedures here that might be considered and some additional procedures. This is the checklist that I use for my patients. I just added some underlines here. Diabetic foot. How to treat it. Here are just some recommendations: washing the feet, drying the feet, looking for bumps, checking between the toes is key, filing, cutting the toenail, things like that. I use this little diabetic foot checklist, If you're concerned about something, the main thing you want to be concerned with is if someone has neuropathy or they can't feel and they injure their foot, they may have a fracture and you don't know. One of the worst types could be Charcot foot, which is a midfoot fracture, or a fracture somewhere else in the foot that's not diagnosed, might be mistaken for a cellulitis or an infection. So an x-ray goes a long way. If there's some skin problems that you're not sure of, there can be in this patient population a need for a biopsy. There are different types of malignancies that can happen on the skin. Different types of treatments in terms of for blood flow. If there's a lot of swelling, compression stockings, or elevation, doing vascular studies, it's recommended. Anyone that's over the age of 50 with diabetes should do some type of a vascular study, and then non-diabetics over the age of 70. And if there's any abnormalities, sending them for a vascular consult. For the skin, the main things I look at are fungus or ingrown toenails on the nails. Those can be treated in the office by your podiatrist. Calluses, which turn into wounds. Are there any bloody calluses? That's an area of concern. Dry or cracked skin. Check between the toes is key. That can be missed a lot. Pressure, to reduce the pressure, like a bunion, hammertoe. Once again, shoe recommendations. Wide anatomic shoes are the key. For the females, yes, they're going to be ugly, but they may prevent blistering and ulceration. Padding and orthotics also can be helpful. Sensory exam, Sims-Weinstein, you can do that. That's that little monofilament thing that you put on the bottom, or the vibratory. Quick word is that you're going to tend to lose vibration before you're going to lose the sensation with the Sims-Weinstein. So actually the vibration on the big toe is more indicative of neuropathy for those that don't have profound neuropathy. I give my patients some recommendations looking at their feet daily, letting me know if there's any problem. Podiatric foot care and diabetic shoes, that's always a key. You're going to have to talk to your podiatrist because it's kind of complex. Not every diabetic can get foot care. Not every diabetic can get diabetic shoes, but your podiatrist can help you to determine that. There's a good book I recommend my patients read. It's called The Diabetes Code. It has some good resources at weight loss using a topic that I'm pretty passionate about. So if you want to, you can look at that as well. Adult flat feet and posterior tibial tendon dysfunction. Once again, this is that foot that's totally collapsed down. They're walking on the arch. The heel position is turned in. Really, basically, you'd call it a really big flat foot that can affect the tendon. Okay, that's why we call it posterior tibial tendon dysfunction. The diagnosis, you can use an x-ray to help. That'll show you kind of the position of the foot. You can also have them go up on their toes. If they can't go up on their toes, that shows that it's pretty severe. If you want to look at the tendon itself, I like to do an ultrasound or an MRI. Once again, you might do an x-ray before sending him to a specialist. You could try some icing, anti-inflammatories. You could try some stretching, some physical therapy. Physical therapy doesn't help all that much. What's more important is a stable shoe and even a walking boot to really support the area. That's going to be key. Sometimes you need either an ankle brace or an orthotic. The thing is, an orthotic's only underneath the foot and it can't really support that tendon that well. And that's where an actual ankle brace or ankle foot orthotic can be beneficial. And then if none of that works, possibly surgery. Pediatric flat foot, very similar. You can see this would be a child that would develop into something like the other one in the future. They would develop more arthritis and more problems. The way we do that, we get x-rays. If there's pain, certainly, but very rarely do I do an ultrasound or an MRI for kids with flat feet. If they're having pain, they can do some icing or anti-inflammatories. Don't really do shockwave unless it's an area of a tendon that's inflamed. Once again, amniotic tissue therapy, very rare. I do stretching, physical therapy. Supportive shoes and custom orthotics are really the key. Unless they're in a lot of pain, I might put them in a boot to calm things down or do a brace. And then if none of this works, you may want to consider some type of a flat foot reconstruction surgery. Looking at a foot fracture, when should you send a fracture to a podiatrist? There's a couple of types that are confusing. One would be a toe fracture, and the other one would be a fracture somewhere else on the foot or the ankle. For fractures, I think the key, you can start out with x-rays, and if it's not healing or if there's concern for healing, you could send them. Most people do send most of the foot fractures, but not many of the toe fractures. Toe fractures, though, if they're not getting better after 6 to 8 weeks, you should probably send them, or even sooner, to make sure there's no malalignment of the bones. Foot fractures, you want to send. Fifth metatarsal fractures are very common. Stress fractures are typically not seen on the x-ray, and you'll find that more with like a vibratory tuning fork on that bone. Traditional treatments would be icing, anti-inflammatories, maybe some type of compression if they're swelling, strapping or splinting of the toes with Coban or some other type of thing, or just with tape on itself, depending on what toe it is. Protecting the area with a surgical shoe or a walking boot, and if it's really bad, doing a cast. Ambulating devices, most people come in with crutches. And then if things take a long time, you may need to get a bone stimulator or surgery. So basically, I would try these other things that are underlined first before you send them. You could get an x-ray. That's what most people do, get an x-ray and send them over. Cysts. There are different areas that cysts can be on the foot. I just want to explain that a cyst usually comes from a joint. You can see a joint or a tendon sheath. That's where they come from. They might go away, but if they don't go away, you should probably send them. There are a few things you can try. You can get an x-ray. The only reason I get an x-ray is to see where it's coming from, if it's coming from the joint or the tendon itself. From the joint, I'll actually put a metallic marker, if it's a real small one, right on the area of it, so I can see where it's kind of coming from. An ultrasound can also help you to determine if it's coming from the sheath of the tendon. MRI, I don't do too many MRIs unless I'm concerned or I can't see it with an ultrasound, or I want to just verify or how big it is, the extent. Traditional treatments, icing doesn't really do much. Aspiration, really taking it out, and then either doing compression or cortisone. I don't know if cortisone really adds much to it, but some people like to do cortisone into it as well. Sometimes it can cause maybe shrink down that sac, that balloon type of thing, and make it close off. And then there are different types of surgeries that can be used to remove it, or fusing of the bone if it's in a toe. Removal has a high recurrence rate, so just be aware of that. Gout. A lot of people refer to us for chronic gout that's not getting better. Here's an example, just a schematic of some gouty crystals. Here's gouty crystals coming out of a patient's toe, and here are just the red hot swollen joint. That's what you're gonna see is a red hot swollen joint that's really, really painful for patients. And how do you treat it? Well, you can start with an x-ray. I don't usually get MRIs that often, but sometimes an MRI can be helpful. An ultrasound can be helpful as well. If you're not seeing what's going on, a blood test is key. You're going to look for uric acid. A lot of times, though, it's going to be trending down by the time you see it, so they might still have gout, in the uric acid may be normal. I don't do too many joint aspirations. I think my colleagues in rheumatology tend to do more of those, unless I'm really concerned about like infection versus gout. For my patients, I'll usually ice, anti-inflammatory, maybe oral prednisone if they don't want an injection. Otherwise, I'll do an injection. Put them in a walking boot if there's a lot of pain or if they don't want an injection. And then there's a lot of medications you can see here you can try. And then surgery. When do you remove the gouty tophi? Very, very rarely. Only if it's hindering ulcer healing. You might have to remove some of that. If the ulcer's not healing, cut out or remove some of that. So that's for gout. Haglund's deformity. That's a big bump on the back of the heel. You can see here, sometimes there can be a bursal sac. There's different areas, and it rubs on the back of the heel. How do you treat the Haglunds? X-rays to start. You can do diagnostic ultrasound to see if the area is at the bone itself or on the side of the bone. An MRI can be helpful sometimes. Usually it's not needed unless there's some other concerns with it. To reduce the inflammation, icing, anti-inflammatories. I like contrast baths. So that's a bucket of ice water first and then hot water, then ice water, so 5 minutes in each. Cortisone, I put it up there. Not that I do cortisone to the Haglunds. I want to explain, be very, very clear. Sometimes the bursal sac that's there, if I do it with an ultrasound, I can get it just in the sac. I want to stay away from the Achilles to not cause any rupture. Or if it's on the side of the heel, if it's on the side far away from the Achilles, I can sometimes put a little bit in there and it can help. And I always put them in a walking boot if I do that after. Shockwave is actually my preferred method now, where I hit the area. It increases the good blood flow to the area to help bring healing. You can reduce tightness with stretching, physical therapy. Night splints can help sometimes. Heel lifts tend to help quite a bit just to reduce the pull on the Achilles, and then stabilize the heel with supportive shoes, custom orthotics. And then there are some advanced treatments or surgery if nothing gets better. Let's go on to hallux limitus. This is a painful big toe joint, and a lot of times it's due to arthritis. So you'll see here there's a lot of jamming in the joint when you get your x-ray. An ultrasound I might do if I can't see everything on the x-ray, or if I want to see if it's inflamed. Icing, anti-inflammatories. My go-to really is a cortisone injection, and then looking at the x-ray to see how bad it is, depending on the severity. If it's really hurting when I'm moving, I might try to calm it down with the cortisone first, maybe with some physical therapy. Usually physical therapy, though, could aggravate it. A walking boot can really help people stop the movement of it. Shockwave therapy hits the area, and once again can make it better if someone doesn't want cortisone. Doing a wider shoe can help as well, like an anatomic shoe, and then correct toes can be helpful as well. Custom orthotics as well can be helpful, and a rigid shoe can be helpful. I like a carbon fiber insert that just helps reduce the movement in that area. And then there are some advanced treatments like surgery for fusing the joint or other types of things with the joint. Let's talk about hammertoes quickly. Hammertoes, these are these bumps that can either cause just ugly toes or ulcers, things like that. X-ray is the way to start to look at them. Very rarely do I do an ultrasound or an MRI. Icing anti-inflammatories can be helpful. Cortisone injection in the joint if it's just one joint and really painful. Walking boot, but the main key really here is offloading. So trim the calluses, use cushions, an anatomic shoe with a really wide, deep heel, toe box. Correct toes can help if people are not wanting the surgery, they're wanting just to kind of rest the area. There are some stretching exercises that have been known to help a little bit. I haven't had the best success with the stretching component of it. Ingrown toenails. What do you do? Most people send them over, but if they want to try some things, you could certainly try to trim down the side. You can try to pull down the skin. You can try to soak it. Putting them on an antibiotic is a good way to help before they can come in to see us as podiatrists. When would I use an x-ray? I would use an x-ray if it's a recurrent ingrown toenail and I'm concerned that they may have a bone spur. Same thing with an MRI, would be more of like a bone spur, or if there's a really bad one and I'm concerned about an infection into the bone. When they see us, we remove the side of the nail pretty much all the time. And then we very rarely put them on antibiotics unless they need it. And then if it keeps coming back, we'll do a matrixectomy. That's where we kill the side of the nail or shave down the bone spur. And that's the surgical component, the nail matrix. It's a very common procedure we do. Forefoot pain. Okay, we're finishing up, only a few more diagnoses. So forefoot pain is a very broad problem. It's usually pain in the ball of the foot. It can be caused from a bone that's further down. This is kind of a front-on view looking. This is the big toe joint with the sesamoid. So the sesamoids can be painful. There can be a callus from a bone that's further down. There can be a plantar plate tear, stress fracture, bone swelling. Metatarsal length can be longer. Metatarsalgia, which is painful under the ball of the foot. Hammertoes. All these things can be, and then biomechanics can be a problem, like how the patient walks. Now this is really hard to throw forefoot pain in one big category, but to start, getting an x-ray is a good way to start. When they come and see me, I'll usually do a diagnostic ultrasound. Very, very rarely I'll do an MRI. Cortisone injection, very, very rare if it's in the joints. Okay, joints, I don't do it because it can destabilize the joint. So I'd be very, very aware. I do a shockwave a lot where I hit the area of inflamed joint to reduce the inflammation. Icing, anti-inflammatories, contrast baths, strapping or just stabilizing it, and then putting someone in a walking boot to have them rest. The problem is patients don't typically rest, so have them rest. Physical therapy sometimes can help. Supportive shoes are really the key. Supportive anatomic shoes that are very wide. Different types of cushions or pads that can be added to the shoe or added to the orthotic. And then strapping the toe if needed. And then surgery can be used for this as well. So that's very broad. There's a lot that goes into forefoot pain. You really have to make the proper diagnosis. So I would send them to the specialist sooner versus later. Okay. Nail fungus, a lot of different types of nail fungus. This is pretty typical. This is the real thick ram's horn. This is kind of one of the elevation, and this is one that has just the superficial white that can be seen when people take off their nail polish at the end of the season. I use this little thing, this little chart that I use, just makes it easier when I explain to patients. So basically I have here on the top the treatment, effectiveness rate, ease of use, recurrence rate, and concerns. So let's start with topical. There's like 500 topicals that you can buy over the counter. There's Vicks. There's some that you can get by prescription. I kind of throw them all in the same boat, about 6 to 20%. I don't find them all that effective. Maybe if you have one toe or a part of a toenail that's affected, you have to put them on for a long time. So that's one of the main reasons. It's not very easy to use. There's a high recurrence rate, more because of incomplete treatment. That's my main concern. So it's better for mild or one nail. Oral medication, I still like that the best. I say it's 60 to 80%. I give that out a lot. I know there's a lot of doctors maybe that don't feel comfortable giving it. So send it to us. We do this a lot. We get liver function tests, and I've never had a problem. Maybe you have, and that's why you don't give it, but I've never had a problem. You take one pill for 3 months and then maybe a booster or do it again. High recurrence rate no matter what, though, that's what I put. And I think incomplete cure after one round of Lamisil is the biggest problem for recurrence. So it might not totally clear in 3 months, definitely won't clear in 3 months. It takes about a whole year. So you have to monitor that and then possibly put them on it again. And you have to monitor the liver function test. Laser treatment, I wish laser was great. I really haven't seen the best results with it. I put it at 40%. They're quick treatments, high recurrence rate, mostly from incomplete cure. Patients that don't want to do the oral medication, I recommend laser. If you wanted to try something, you can. It's quite expensive. Every doctor has their own price for it. There are some cosmetic things that my patients do. One's called nail resurfacing. This is an example here at bottom on the left here of a fake nail, or like a nail that it can be either done at your pedicurist, or some podiatrists do Cariflex. It's cosmetic. You do it about every 3 months in the summertime. A little bit expensive, a lot less than the laser. So that's an option. And then removal. I think removal is a fine option. You can actually just numb the toenail and take off the toenail. I'd say about 50%, so probably the same as laser. It's easy relatively to do. Recurrence rate, I say 50-50. So and there's two options, a permanent or a non-permanent. The permanent would be where we kill the matrix and they have no toenail. That would be more for a thickened nail that's really painful and ingrown. I might do that. But if someone just wants one or a couple of nails removed, we can try it and see if the nail will grow back normal. The big problem I have with removal is that sometimes the tip or the tip of the toe can lift up. And so as it's growing out, it can get grown in at the tip. That's one of the problems that you can have with that, but that's something we deal with. Neuroma is a painful nerve called Morton's neuroma between the third and the fourth interspace. This usually people feel like they have a bunched up sock in their shoe. And I start with an x-ray, then I'll usually do an ultrasound to measure the size. MRI don't do that much anymore with ultrasound, but if I want to measure the actual size and see if there's any other things going on, I start with people icing, anti-inflammatories. I only do a walking boot because it's wide. That's the main reason. So I would have an anatomic shoe, very, very wide shoe. They can try an insert or a custom orthotic or even correct toes if they want to. Stretching, I guess stretching can help a little bit, but I think shoes are more important. And then occasionally I'll do a cortisone injection in there, or sclerosing, or surgery to remove it. I don't do that much sclerosing, but that's something that's in our literature that some people do. Peroneal tendon pain. Here's pain to the peroneals. That's on the side of the ankle. Sometimes they can be torn. Sometimes it can be painful at the base where it inserts into the fifth metatarsal. Sometimes there can be synovitis. I kind of call that arthritis of the tendon. And how do you treat it? Well, I would get an x-ray first. That should be underlined. Then if I'm not seeing it like an accessory bone, sometimes there can be an os peroneum or another extra bone in there. I might do an ultrasound to see if I see any inflammation either in the tendon or around the tendon. That's the benefit of an ultrasound. It shows me in or out. I can do icing, anti-inflammatory. If there's a specific place, I can do a cortisone injection. I don't do too many of those to not weaken the tendon. Walking boot to rest, stretching, physical therapy, home therapy, supportive shoes. And then if it's not getting better, I'll put them in a walking boot and then maybe transition them to some type of a brace or ankle foot orthotic. I'm doing more and more shockwave now on painful peroneals to help increase the blood flow and healing to those areas. And then you can also do amniotic tissue, allograft, PRP, and then surgery if things aren't getting better or not getting better as quick as you want them. Plantar fasciitis or plantar fibroma. Totally different creatures, but the treatments are a little bit alike. 99% of what we see is fasciitis. Fibroma is 1%. Pain to the bottom of the heel, pain when they get up in the morning. Everyone sees this all the time. The biggest thing is making the correct diagnosis, and it's not something else, like a bursitis. Imaging, I would get an x-ray. I try to treatments initially, and if it's not getting better, I'll do a diagnostic ultrasound. I'll measure the thickness. I have some certain measurements that I know that are common for normal and abnormal. I start a lot of times now with shockwave. If their pain level is like 5, 6, or 7, I'll do shockwave. If it's 8, 9, or 10, I'll do cortisone. Anti-inflammatories, icing, contrast baths, physical therapy, all the same things. You can see it's very repetitive, what we do over and over. Foam rolling, I think, is key to the back of the calf. I do that for the home therapy, foam rolling, or using one of the other devices. A night splint can be used sometimes. And then to stabilize the foot, a custom orthotic or supportive shoes with taping, a walking boot, ankle brace. I don't use ankle braces that much for this. And then there are some advanced treatment like amnio injections, PRP, or surgery. Surgery, we don't do that much of. We're usually pretty good at getting people better. The biggest problem is when people wait a long time to come in to see us. So they think it'll just get better, and it just doesn't. So that's going to be a challenge. Sesamoiditis is pain on the big toe, underneath the big toe right here. It can be a sesamoid fracture or a two-pieced sesamoid, as the picture shows. So either a sesamoiditis or a fracture, I would start with x-rays. Then if I'm unsure, I would get an ultrasound or an MRI to determine if it's bipartite or if it is a fracture. That's the key for sesamoiditis. Treatments, icing, cortisone. If it's a bipartite, you could do cortisone. If it's a fracture, tend not to recommend unless it's the last resort before removal. Strapping just doesn't let the toe bend. Resting it in a walking boot. Shockwave has some good results for sesamoiditis and just painful sesamoids and even fractures that are slow to heal because the sesamoid doesn't have the best blood flow. So shockwave can be helpful. Amnio is an option as well. Reducing the tightness. What I mean by that, with stretching or foam rolling or physical therapy, that's all working in the back of the calf. Because if the calf is tight, it's going to put more pressure to the forefoot, and that's going to make it be more painful. Supportive shoes, custom orthotics to offload that area. And then if nothing's working, maybe a cast, crutches. I didn't put on here a bone stimulator. That could be another option. And then surgical removal is an option as well. Seaver's disease or calcaneal apophysitis. This is something that kids have when you squeeze the side of the heel. There are certain age ranges that kids get this. So when you see them, if they have heel pain, plantar fasciitis is not very common in kids. So if you think it's plantar fasciitis, it's probably Seaver's. Tends to be worse when kids jump up and down or on running sports. The imaging I would do would be an x-ray. If I don't really do many ultrasounds or MRIs on these. Icing, anti-inflammatories. You could try a walking boot to basically to make the kids slow down. You could do stretching. That's more for the calf. Once again, pulling on the calf is pulling on that growth plate. Physical therapy, pulling to reduce the pulling. Supportive shoes, custom orthotic. There's different types of cups, a heel cup or a heel cushion or a heel lift. And then, I don't really do shockwave therapy for this, but because of the concern of closing that growth plate, but that would be a possibility. So if it's not getting better, I would send them to see, and it will go away over time. The problem is kids don't slow down, and that's the whole challenge with this. Turf toe, very similar to sesamoiditis, is underneath the big toe. Could be from jamming of the joint, and this whole joint becomes painful. So you have to determine, do they have turf toe? A lot of times turf toe is pain on the top versus in the bottom, and it can cause a sprain of that area. Similar treatment, though, to sesamoiditis, getting an x-ray. If I'm unsure, I'll do an ultrasound or an MRI. Doing icing. Cortisone injections are very common for this. A walking boot is very common to reduce the movement. Shockwave works very well too, especially if it's not a fracture, just to help get down some of that swelling and inflammation. Physical therapy, not too much. Supportive shoe, toe strapping, a Morton's extension. Basically, that's an orthotic with a extension underneath the big toe joint so it doesn't bend. And same thing with a carbon fiber insert. That's something that goes under the sock liner in your shoe to prevent movement. And then occasionally surgery is needed for turf toe. Going on to warts, everyone sees warts. The biggest thing for warts is determining, is it a wart or a callus? That's something you're going to have to determine, but that's the hardest thing to do because a lot of times warts look like warts, but they're calluses and vice versa. I use this little treatment method for the options. So there's the treatment method, number of visits, pain level, recurrence, and just different notes. This is what I show to patients. Basically, the quickest option is to do removal. I don't do a lot of removal. I don't do any needling. I just put that here for completion. Do surgery plus 2 to 3 post-ops. Hurts a lot, the injection mostly, and then has recurrence can happen around the edges, or if you don't go deep enough. It takes 4 to 6 weeks, but there can be a wound and there would be scarring. So not everyone chooses, especially if you have multiple warts or mosaic, multiple warts in one area. My treatment of choice right now is cantharidin, which is, we call it Beetlejuice. It still takes a lot of visits, creates a really big blister for about 3 days, up to a week. Low recurrence rate once it's gone. The big thing with all these is making sure it's gone. If it's still there because it's microscopic and viral, then it'll come back. So basically I say, if it comes back in the same spot, it's because it was never really gone. If it comes back somewhere else, it's because it's just a recurrence somewhere else. So it's painful to walk. Salicylic acid, there's multiple types you can buy over the counter. Patients usually start this before they come and see me. I don't ever use it as a treatment unless it's like on a child. And even then, I usually use cantharidin and just have them leave it on less time. Pain's very low, but it doesn't really do much. People try that before they come and see me. I still use laser a lot. Problem with laser is it hurts. If it's on a bony prominence or a prominent area. Takes a lot of visits still. A lot of times I'm doing laser with cantharidin. So I'll laser them if they can tolerate it and then put the cantharidin on top. It creates a hard blister, kind of like this thing, like a blood blister you can see on the side. And here's what the other ones do. Like the cantharidin creates a big blister as well in that area. And this is an example of removal afterwards. The last option would be some type of a topical. There's a couple of anti-genital wart medications, or this Carac is actually used for on the face for actinic keratosis and other things. I don't use these that much. There's no pain. They don't really do much. Some people advocate them all the time. I don't have the habit of using them a lot. I usually use one of these other treatments, but I'd like to know if you prefer using them. And then wounds, I'm not going to go into a lot of depth. This is going to be a couple of lectures on itself. I'll put some resources on the bottom about wounds if you'd like to know. But the gist of it is, if you're concerned about bone infection, I would get an X-ray or an MRI. If you're concerned about any type of malignancy, a wart that's a long standing, you might want to get a biopsy. What you can do to reduce the pressure would be like padding in an orthotic or a surgical shoe, basically staying off the foot, which is really hard if they have neuropathy. Big football dressing, that's just a huge padded dressing. For blood flow, get compression. If there's a wound on the leg, use compression so it'll close. Vascular studies, vascular consult. Infectious disease, if there's an infection, admit them to the hospital if there's cellulitis. This is very quick. This is just my little checklist that I use. For blood sugar, get a nutritionist or an endocrinologist to help with the blood sugar, because if the sugar is too high, it's going to be really hard to heal that wound. Wound dressings, there's literally hundreds, possibly getting visiting nurses, and then advanced treatments would be surgery or wound care referral. Okay. So once again, I hope you enjoyed this, kind of a lot about how to refer and when to refer to podiatry, but just I took some of the basics and went over some of how the basic treatment options, what you could try before you come and send them to us. Hope you found it helpful. Here's a little QR code if you want to get this. I'm going to put this presentation along with some other resources you can click to download with this. Okay. If you have any questions or comments, please do that at the bottom of the video. Okay. Thank you so much.